Hello. We are gonna get started tonight. My name is Megan Linton, and I will be facilitating tonight's panel and probably also offering my 2 cents. I'm part of the Disability Justice Network of Ontario, which was founded in 2018 and is currently based out of Hamilton, Ontario, the city with the largest density of disabled people in the province of Ontario. And it's hoping to expand to other cities in the next couple of years. I first want to acknowledge that I am situated on the unceded and illegally occupied territories of the Algonquin Anishinaabe people. DJNO as an organization is also based on the occupied territories of the Anishinaabe and Haudenosaunee people. On land covered by the Dish with One Spoon Wampum Belt Covenant. I would like to take a moment to mention and encourage people to support 1492 Land Back Lane, where Six Nations land defenders continue to reclaim their territory and have faced violent state repression in doing so. We understand that disability justice means upholding Indigenous sovereignty, and I would like to invite other settlers to learn more about the nations whose land you currently occupy and how to support their ongoing struggles against settler colonialism wherever you are. Settler colonialism brought with it the violent construction of prisons, residential schools, institutions for disabled people, asylums, long-term care, and prisons. Today, institutions continue to forcibly remove Indigenous people from their communities. The Ontario Long-Term Care Commission found that Indigenous elders in long-term care, especially those who only speak an Indigenous language, are completely cut off from social contact with their families, with the local Indigenous community, and with society overall. Long-term care has always been a site of confinement and slow death. But this past year, we have also seen an acceleration of the violence and debilitation that happens within long-term care. Disabled elders left to die, subject to overusage of antipsychotic medication or chemical restraints, and completely isolated from their communities. In these conditions, they were forced to endure. Many of them perished in a fashion in which they were killed by state violence. And this violence is ignoring and isolating our elders and our community members. As we move forward from COVID, we also remember that this was not unique to this pandemic. In pandemics leading up to this, we've known that disabled people and institutionalized people will be at disproportionate risk for higher mortality rates and higher incidences of the virus. I am very excited to hear from our panelists today, who are all just such amazing activists in their own right. I'm gonna introduce them first, and then we'll go through start getting into the questions. Nora Loretto is an activist based in Quebec City and the author of Take Back the Fight, Organizing Feminism in the Digital Age. And From Demonized to Organized, Building the New Union Movement. Nora is the editor of the Canadian Association of Labor Media and a sought-after facilitator. She writes regularly for magazines, newspapers, and online outlets. She speaks about social movement organizing, activism, the far right, and many other topics. She also co-hosts the amazing podcast, Sandy and Nora Talk Politics with Sandy Hudson. Locally, Nora is involved in many solidarity and anti-Islamophobia movements. Thanks for joining us today. Along with Nora, we have Judith Sandis. Judith has had many years as an educator, administrator, researcher, author, executive director, advocate, and consultant. Throughout her career, her focus has been on issues facing vulnerable people, including those living with disabilities. Judith retired from Ryerson University 5 years ago. During her time there, she was a sessional instructor, faculty member, Dean of the Faculty of Community Services, Associate Vice President Academic, and Interim Director of the School of Social Work. Prior to this, she worked with organizations for people labeled with intellectual disabilities and was the director of 2 such organizations for a total of 13 years. Currently, Judith is an active member of Seniors for Social Action Ontario, as well as a member of a joint committee of the Seniors for Social Action and Community Living Ontario. And finally, joining us today is Amit Arya. Amit is a palliative care physician who works in long-term care facilities and a health and human rights advocate. He is a faculty member of the Division of Palliative Care at McMaster University and the University of Toronto, and a co-founder of Doctors for Justice in Long-Term Care, a coalition of physicians, researchers, and caregivers calling for fundamental changes to the long-term care system in Ontario. Amit is also a board member on the Canadian Society of Palliative Care Physicians. So after those wonderful introductions, it would be great if we could also hear from you and if you could introduce your work and your connection and engagement with long-term care. Nora, let's start with you.
Great. Hi, everybody. I'm coming from Lévis, which is a city in Quebec, which is not normally where I live. And so my connection to long-term care is mostly as a journalist. I have been tracking the deaths that have happened as a result of COVID every single night in residential care, and the lion's share of those deaths are happening in long-term care facilities. I don't have much personal interaction with the long-term care system, but I will mention that my grandmother, who's the most recent member of my family to live in long-term care, where she did die, she was living in the facility where Elizabeth Wettlaufer had killed her last victim. And so when that happened, I felt very close to that whole situation because it's very, my grandmother was living there, and the last victim was someone whose farm was not far from my family's farm. So I've been writing with an eye to long-term care probably since 2018, but certainly people now know my work more as it relates to the daily tracking that I've been doing.
Amit, do you want to introduce yourself?
Yeah, for sure. So I'm really thrilled to sort of be a part of this panel, and I'm hoping to learn from my fellow panelists tonight as well. So I'm a palliative care physician, and I do a lot of my work in long-term care, but also in the hospital system and in home care. My academic work, including research and education, is really focused on improving the working and living conditions of people in long-term care and the home care system. I'll add that through COVID-19, I actually was, I led my hospital's rapid response teams into many local for-profit long-term care homes that had large-scale COVID-19 outbreaks of over 100 people infected. And through that, we sort of spoke to many other sort of fellow advocates and researchers and physicians. And as was mentioned, I'm a co-founder of Doctors for Justice in Long-Term Care as well. So once again, thank you so much for having me.
Thanks, Amit. Judith, that leaves you.
Involvement is through Seniors for Social Action Ontario. But throughout my career, I have been very involved in working with, teaching about, consulting about, advocating for people with disabilities. Most often people labeled with an intellectual disability, but also involved with other groups. One of the things that I know very well is that certain groups in our society are treated poorly because society devalues them. And I have always tried to help my students understand that. And so I have always been, I've been always including in my teaching a focus on people who are elderly, because the conditions they experience are so very much like the conditions that people with intellectual disabilities experience. And that helps people to understand that what we're talking about is a phenomenon of devaluation rather than bad things happening simply because people have a certain characteristic or a certain condition.
Thank you. I'm going to introduce myself. So I have been working within the long-term or advocating against the long-term care system since I was about 11 years old and began volunteering in long-term care, and immediately did not like the smell or the environment, and it just did not seem right. I was saying earlier that I was radicalized by the Disney Channel's The Proud Family Thelma and Louise episode, which we'll link. But for the past 6 years, I have been doing research into the use of institutions for people with intellectual and developmental disabilities. And my research really changed during COVID when we began to see the rapid impact of COVID-19 on the sector. As a disabled person and someone studying the intersections of institutionalization and long-term care, I really found that there was an absence of conversations about the overusage and reliance on long-term care and the specific impacts of COVID-19 on adults with intellectual disabilities. We know that across Ontario, at least 3,200 young people are incarcerated in long-term care settings and forced to live there for sometimes decades. Beyond this, we know that there's lots of connections between carceral spaces such as prisons and long-term care. So I'm wondering if you can touch on the intersections of these carceral spaces. Amit, do you want to start us off?
Yeah, so I mean, when I sort of hear this question, of course, there's a historical context where we know that our long-term care system actually has its origin in the penal system and not in the healthcare system. So this is sort of through the Elizabethan era in England, when they had these poorhouses and workhouses, and people who were inmates, people who were elderly, people living with a disability were subjected to hard labor and overcrowding and poor food in these workhouses. I mean, sounds kind of familiar when we talk about today. And then through settler colonialism, when people from Britain were coming to Upper Canada, these workhouses sort of started up in sort of Upper Canada, and once again housed people together in these facilities. Eventually, these facilities became separate. So, there was a separate home for people who were unwed mothers, and then a separate home for the elderly, and so on. And then it was only after World War II that through, social programs, that the government started taking a look at what was happening in these facilities. Now, I briefly wanted to talk a little bit about my own experiences as a physician, where I sort of work with patients and I work with families about these decisions. And I will tell you, from years of working as a palliative care doctor, I have yet to meet someone who wanted to go into a long-term care facility. And I would really say no one wants to go into a long-term care facility. Almost everyone that I meet wants to be in a home, their own home, and the system fails to do that. And long-term care is a disposition or a place that people go when the means to survive and actually do well are completely removed from them, everywhere else. So I think that's something that's very important for us to address. And I'll add that all long-term care homes, including the ones that I work in, have lockdown units for people who live with dementia, because with dementia, there's a common tendency for people to be restless and often be walking around in the evening and nighttime typically. And because our current system does not provide them the resources to safely do that in their community, or even in these so-called long-term care homes, then they're in these lockdown units. And I feel that that's a fundamental violation of human rights, dignity, and autonomy. During COVID-19, of course, we saw that people were forcibly confined to their rooms, and I believe that was already mentioned. And even when the harm from this confinement was known, what this means, and people were still dying from COVID-19 anyways, the policies of isolation actually continued. And I'll add, sort of specifically in this situation, that, we know that in many of these long-term care homes, the reason that people were sort of able to somehow make things work is because of family caregivers. So family caregivers would come in and sort of do the work that was not provided by the staff, because there aren't enough staff in any long-term care home. So family caregivers would be performing frontline work, changing people, bathing people, taking them to the bathroom, and so on. And maybe family caregivers, I'll admit, is the wrong word, because not everybody has families. So sometimes it would be friends, sometimes it could be a private caregiver as well. But one important reason as to why family caregivers or loved ones who are caregivers come in is also for accountability, because they were the eyes and ears in these homes and would call out any problems immediately. And this is fundamentally why I believe these policies continued for so long, is to actually prevent the story from escaping long-term care and prevent the public from actually finding out about the horrific conditions inside. And the root cause of this, or one of the root causes, is because these were private for-profit long-term care homes, which have a fiduciary relationship to shareholders, not to their residents, not to the health workers, and not to the families.
Thanks, Amit. Judith, do you want to jump in?
I think Amit answered several questions ahead. Okay, I don't think that's fair, Amit. But we will get over back to them many times in this, because the issues clearly overlap. It's very hard to focus on very specific things. I tried to focus. What are the connections? And of course, as Amit has noted, they have the same. They share the same origin. They're part of a dynamic in our society where people who are devalued for whatever reason are segregated and put away where they're out of sight and out of mind. And he mentioned, unmarried women, okay, or young unmarried women who would be sent off. And so here we have two groups that people in their minds think are very different in some ways, but they are being treated very, very much the same. They are being congregated, segregated, moved to their own place, away, out of sight, and ignored. And the other thing, of course, is that the conditions under which they're living are very much the same. They lack autonomy, they lack privacy, they lack control of their own lives, they lack relationships. They lack meaningful activity. They're left to just sit and do nothing, and on and on. So there are very, very clear connections. And I think that's important to remind ourselves that it isn't the specific characteristic, but it is a society that does terrible things to groups of people that they don't really want. Okay? So I'll leave it at that.
Nora?
Yes, thank you. So I mean, everything that has just been said is exactly I think the way we should be looking at this at the answer to this question. But I was reminded of this kind of bizarre situation that happened this past week with my research. I have been trying to find out how many people in the custody of the province of Ontario in prisons have died as a result of COVID-19. This is data that the Quebec government puts out. This is data that the federal government puts out. Other provinces put out too. And I was bounced to two ministries. And when I talked to the ministry, the Solicitor General, they said that they don't know, that has to go through the coroner's office. The coroner doesn't know. And so I'm waiting to hear back information about that. And it is exactly the same way that they are approaching long-term care as well, right? That we just don't know. Megan has done such an amount of research specifically looking at residences for disabled adults and children and finding out who has died and how many people have died. And I think starting at the most basic level, looking at a pandemic and being able to count how many people have died and not being able to arrive at certain numbers is just evidence of the location within society that these facilities occupy. And Amit, of course, talking about the role that profit plays as well is really, really important. Though, I come from a province I come from Ontario, so I know Ontario, but I live in a province where 90% of long-term care is public, and where like so many more people died in Quebec. Now we can talk about some of the ways that death is counted and how that number is not probably as high, because in Ontario, just because you had COVID at the moment of death doesn't mean that you got recorded as a COVID death. But the long-term care system here is in such disarray, and a lot of it's connected to the fact that folks are living in institutions that had been religious institutions, that had been set up to be religious institutions that just cannot accommodate people with the complex medical needs that are required for long-term care. And so rather than fixing this, we've got governments that have, our current government was elected on the promise that they would fix long-term care. It was one of the key promises that got them elected. And what did they do in the first 2 years? They attacked taxi drivers, they attacked Anglophones, they attacked people who wear religious symbols. And so it's like, oh, wait a minute. Oh, minority communities. They attack minority communities rather than actually doing anything about the system of long-term care here, which are called CHSLDs. And so when the pandemic happened, you had this situation where the government, which decided, like many governments in Canada decided, to keep hospitals open at all costs, right? That they had to clear emergency wards at all costs to make sure that there was enough space to be able to deal with people who got sick from COVID. What happened was that people were then being sent to long-term care, or they were being kept in long-term care. We got an inquiry going on with the CHSLD Saint-Dorothée, which is the location of the most number of deaths, more than 100 deaths at the CHSLD Saint-Dorothée in Laval, which is near Montreal. And in the inquiry, we're finding out there wasn't enough oxygen, that staff were treating respiratory illness with morphine rather than treating respiratory illness like, with oxygen and with other ways to treat it like that. And so just shows just how little the system actually mattered in a crisis, right? In a crisis is the moment you're going to see these things come to bear, right? And part of that, of course, is the institutionalization. Part of that is the relationship that the people that live in with these institutions have to work. And so if you're no longer deemed useful to society, then society warehouses you in these kinds of institutions in these locations. And obviously we'll explore this a lot more over the rest of this session.
Thanks so much. Yeah, one of the things that always strikes me, well, there's two things. One is the use of psychotropic medication across prisons and, of course, psychiatric units, but also long-term care facilities. So these medications, which are proven to be incredibly dangerous to elders, are continually prescribed and forcibly administered such that people can be like zombies and people can be less argumentative and less defensive and even advocate for themselves less. We know that within long-term care, in some settings, there was up to 90% usage of chemical restraints administered against the population. This is very similar in women's prisons, where a Correctional Services Canada investigation found that more than 2/3 of the population was being administered antipsychotic medication, not for any symptoms of psychoses, but just as a backup. The second thing that strikes me is I do most of my research on intellectual and developmental disabilities. And I think one of the really important things about the deinstitutionalization movement, which closed down many of these large institutions for disabled people, was that it could never be fully realized as long as we have these other types of institutions. And we can see that so clearly in both long-term care and in prisons. So within long-term care, we know that there is a significant but unknown number of adults with intellectual disabilities under the age of 55. We should know that number. I'm working very hard on it, but we don't. And we also know that there's a disproportionately high number of adults with developmental disabilities who are incarcerated. And in both of these settings, it's not because they are meant to be there. It's not because anyone is meant to be there, but they're used as these backstops. And so we can see how this cycle of institutionalization maintains itself in its present structures through long-term care and through prisons and through our psychiatric system. So turning to COVID-19, We know that COVID resulted in the mass death of thousands of elders and disabled people confined in long-term care. But why did it take this tragedy for people to finally care about the conditions within long-term care? And how did you feel about the media coverage of long-term care within mainstream media? Nora, I'm eager to hear your answer to the second part of that question, so I'm gonna pop it over to you.
Sure. I think the answer to the first question is kind of simple. Like, I don't know if this is what made people turn on to realizing long-term care was bad. I think that there has been more than enough evidence over the last many years that shows that the system is in a crisis. And specifically, I'm thinking around the wet law for inquiry. You know, there was many recommendations that were made, and I think of the words of the commissioner, Eileen Gillespie, or Gillies, who said in her introduction to that report, like that this work is to hopefully make it the case that none of the people who were the victims of Elizabeth Loffer their lives were in vain, were lost in vain. And then, you know, fast forward a year and most of the recommendations remain unfulfilled. And then fast forward another 6 months just before the pandemic in February, and you've got the provincial government stacking a committee on long-term care staffing with no staff representatives, with representatives like James Schlegel, who owns Schlegel Villages, which is still in the news because while there's only, I think, 5 or 6 facilities that still have an outbreak in long-term care facilities, one is a Schlegel outbreak. It's a Schlegel-owned home, and it's in Burlington, Ontario, Tansley Woods, and there's 6 people who have died there. And so I think that the horrors that we're going to be talking about tonight, and have already mentioned, were well known. The real question is, what is it going to take to get politicians to take this seriously? And that, I think, is a much more difficult question, because then you get into capitalism, then you get into those political connections, and and of course you get into the cost that it actually takes to care for people, which is significant, but not insurpassable, right? Like this is money that as a society we should be prepared to spend. The question of media, the media coverage is something I spent a lot of time thinking about and writing about. And I find it very interesting because it seems to me that the media coverage has always had to have some sort of hook, like what we've talked about tonight. You know, the private long-term care is more deadly than public long-term care. And I saw a comment already reminding us to make sure that we don't necessarily say that without the caveat that there's problems in public long-term care as well, which I kind of alluded to when I mentioned that Quebec's system is overwhelmingly public. It's the logic in the system of private for-profit care that is so deadly. And that logic is driven by the private operators and owners, obviously, and they make a lot of money off of that. The extended cares, the Chartwells, the Riveras, the Schlegels. But the logic that comes along with those operators bleeds throughout the entire system. And, you know, one of the facilities where there was, I think, 15 deaths in Etobicoke is a public facility that is still managed by Extended Care, one of these private for-profit providers, right? And so when you have these private for-profit providers helping to set standards, pushing back against regulation, driving wages into the ground, juicing the political machinery to allow the absolute worst standards of care to be what is normal, then of course it's going to infect the entire public system as well. And journalists never, ever, ever, ever talked about that enough. Instead, we get, oh, well, you know, Extended Care makes lots of money. Every time they make money, they're cutting back somewhere. We're not going to examine too much where. We'll look at the room design. We'll look at like other architectural features, and we'll kind of leave it there. And it's like, that's fine. That's all. Like, if you're discovering this for the first time, that's a fine thing to discover for the first time. That at month 16, that this is still where we're at in understanding the role that the conditions of long-term care have created and led to all of these deaths in this country. Like, that's what's unacceptable. And journalists have been incapable of naming clearly these problems, and instead kind of like brushing over with a large brush. I'll just finish with one example. So the Toronto Star just had a big expose on lobbyists and how lobbyists were driving the agenda, the Ford government agenda, on a whole bunch of different issues, not just long-term care or healthcare. But in the article on long-term care, there's this really weird like lack of mention of Chartwell. so it goes through all of the major operators and who's lobbying for them and how they've all hired old conservatives or current conservatives, including the former director of communications of the current minister of long-term care, now lobbying for the mostly for-profit lobby group for the Ontario Long-Term Care Association. But they didn't mention Chartwell, and it's probably because under the lobbyist registry they're not listed as Chartwell. They're listed as a real estate holding firm called HCN. And I guess if you don't know that, it's hard to find it. But you look and it's like, oh my goodness, this is being run by Jenny Byrne, who was Stephen Harper's whip sharp, young, hot rod campaign manager for the 2015 campaign. So the connections can sometimes are made sometimes, but even when they're made, they're not brought out in such a way that allows citizens to really understand just how deep this goes, and why when we talk about something like as fundamental as deinstitutionalization, we're not talking about reform, because the reforms are impossible to actually fix what we're talking about. We are talking about needing to really change fundamentally how the system operates. And journalists, by and large, especially if they collect a paycheck from, Post media, they're not interested in actually having that conversation.
Thanks. Amit, over to you.
Wow. So, I mean, I completely agree with everything that Nora has mentioned and talked about. So just to reiterate, I mean, I absolutely agree that, eliminating private for-profit long-term care will not fix the system. But exactly as you've said, it's the private for-profit, corporations which have fought for decades through these powerful lobbyists to sort of deregulate staffing standards, deregulate inspections, not have enforcement of any type of regulations in long-term care. And I will add, since we're having this very important conversation around deinstitutionalization, I mean, I wonder why Canada, for example, is one of the few countries amongst OECD countries where we disproportionately fund institutionalization in these warehouses. About 80% of funding, as far as I'm aware, goes to having people, it goes to long-term care, which actually is worse for the taxpayer. And of course, it's worse for the people living and working in these long-term care facilities. And only about 20% goes to home care. Many other countries have a flipped model where they actually are providing 2/3 or more of their community investment into home care, which is actually much better for the taxpayer. It's what people want and what people deserve, rather than warehousing them into places. But I wonder as to how the lobby or this powerful corporate lobby is influencing different levels of government so that we will not get that investment in home care. Adding on to that, of course, there's many different layers of how corporatization and oppression work within the system. And home care itself is something which is subject to many, many problems. In Ontario, as far as I'm aware, the agencies which actually provide health workers in home care are vast majority are for-profit, and they treat their health workers very poorly. And once again, the government here in Ontario, and I will apologize, Nora, my lens is kind of focused a little bit, maybe too much on Ontario, but I know that the Conservative government here last summer passed Bill 175, which actually even removed the Patient Bill of Rights from home care and allowed Cabinet to make decisions around changing staffing standards and regulations in home care without bringing it to the legislature. And on top of that, opened the door for further privatization. So I mean, I think it is important that we address this powerful corporate lobby. Of course, getting rid of private for-profit long-term care will not fix the system, but I think it's an important step for us to realize how much influence they have over government. Very briefly, I'll add one more point so I don't go over time. Is, in terms of the coverage in mainstream media, so once again, reiterating what Nora has said, I don't feel that we've taken the deep dive that we need to into the root cause of these issues. And that's partly because our mainstream media is basically owned by 5 corporations. So with that, I mean, I think it's very hard for them to talk about, or to get into depth about, privatization, to talk about capitalism, to talk about, anti-racism, to talk about ableism, because they're part of that broken system and that oppressive system themselves. So until we kind of recognize that our media is not truly free and is not reporting on these issues and is part of this problem, I think maybe we won't get to the root causes.
Thanks so much, Judith. Over to you.
Really hard to be the last person because a lot has been said. But I do have a couple of, first of all, I should tell you that I grew up in Montreal. So it's nice to have somebody from telling me about the Quebec situation. And I was actually shocked to hear that 90% of them were public, of long-term care facilities, although I should have figured it out based on other things that I know about Quebec. But that was interesting. There were a couple of comments that I wanted to respond to. One was that, oh goodness, somebody mentioned that, I think it was Nora, but it doesn't matter, that some of the long-term care facilities weren't able to meet the complex needs of people in long-term care. Now that, I'm sure that is true in some situations, but the reality is that there are a lot of people. The public has the view that all the people in long-term care facilities have complex medical needs, and that's just simply not so. Studies have shown that if there were proper home care, that the majority of them could manage quite nicely outside that system. In fact, when people need complex medical care, they should be sent to a hospital, and in fact, the long-term care facilities did the exact opposite. Okay, so I think we have to do that. The other thing that I wanted to say is I was involved with organizations for people with intellectual disabilities, mostly in the 70s, in the late 60s and in the 70s. And I was involved as we began to move people out of the Ontario institutions. And I was very involved in advocating for the closure of those institutions. And they are, in fact, every single large government-operated long-term institution for people with intellectual disabilities no longer exists. And even some of the smaller ones, the organizations that were operating those got them out. But what we got rid of large government-operated institutions, but we didn't get rid of institutions. We replaced them with small institutions. In my work, I have this, I'm involved in these workshops where we go around and we evaluate, we assess services for different groups using a particular tool. And what we find is that it's incredible how small an institution can be, okay? So good is always bad, but small is not always good. I mean, it's just, however, I am aware that one of the reasons why it was possible to close the large government operated institutions is because they were government operated. It's much harder when they're operated, when they're part of a for-profit system. So that's one of the reasons that they create a major challenge. So those are sort of my first comments, but answering the questions that were posed, that were sent to me, why did it take people, I mean, again, it's the same thing. They didn't know about how bad it was in the long-term care institutions because they really didn't care to know. So they were out of sight, out of mind. It was only when people were sort of hit over the head with these horrible, horrible, horrible tragedies that people began to be aware of it. However, okay, I'm not, the wording was for people to finally care about the conditions within long-term care. I'm not sure that they care. I mean, we're part of a movement. And so we talk to people like us who are concerned, but I don't think the public at large is all as concerned about it as we think they are. And I think that in large measure, they think that if we just clean up those places a little bit, get more staff, have better inspections, everything will be okay. I don't think they have appreciated the inherent unfixability of institutions. I don't think we have managed to get people to that point in spite of doing as much advocacy as we can do, and as much writing and talking and contacting politicians and contacting government people and setting up meetings and writing to our MPPs and all those things, I still think there is very limited appreciation of that. And I worry, I really do worry about that because, and hopefully we'll get into that as we go on. And so I'm going to stop here so that we don't belabor it. But I wish that I thought that people were overall broadly very indignant, and I don't think that they're indignant yet. Okay, they think they should be fixed, but they don't understand that they should be abolished.
Yeah, I mean, I think one of the most effective tactics of warehousing people away, such as with institutions and with prisons, is putting them away from society so that we don't focus on it. And so I think the media has been very much part of this silence, but also not because people haven't been talking and not because there isn't an appetite for change, but I think that it's a really effective tactic to hide away how bad these things are and how absolutely terrible these systems that we have created treat people. And I think lots of people exclusively relate this to the privatization and to the outsourcing and to the industrialization of this industry. But so much of it is bound up in what these institutions were created to do, which was to put people away so that more people could be working, so that more people could be creating profit, and so that they didn't have to think about what it's like to be disabled and what it's like to be forgotten about or put away and restrained for the rest of your life. I think that in regards to so much of this also is that we benefit from this system. And there's a lot of talk about the way in which capitalism affects this, but we also have to recognize that within this specific critique that there is more and what's often called handy capitalism, which is that we create these systems because disabled people can't or won't generate profit for the state or won't generate labor for the state. And instead, we can generate profit off of them by employing people and creating systems. And so even though they're not seen as a population that is doing any good or doing any service to our capitalist system, we are benefiting from that, and we are generating profits regardless if it's a not-for-profit or a private or a public system. It's still generating income for people, and we're still generating money off of these conditions of confinement. So I mean, I think it's really important that I think that sometimes the argument about caring about young people in long-term care removes the ageism from it, but I think it just goes to show that these places are created in order to generate profits, and actually having people there for a significant amount of time, that's going to generate a significant amount of income for these institutions. And I think that neoliberalism did such a good job of transforming so many of these spaces and transforming the deinstitutionalization movement to be one where it is more decentralized and it is more private, and it is thus more difficult to implicate the state and is more difficult to implicate other people and the people who are causing harm. So I do not think that we can reform this industry, and I also don't want to. I don't think that we can reform it in such a way that we are abolishing our current systems. But I think that a lot of movements, and there's been a little bit of pushback about this event, is that means that we don't want changes right now that are going to materially impact the conditions within long-term care. So we know that mainstream movements, particularly labor movements have been advocating for reforms in long-term care. In abolitionist organizing, we know it recognizes the importance of the role of what we call non-reformist reforms. That is, anti-capitalist reforms that do not seek to rely on the current system of institutionalization, but still improve the lives of those currently incarcerated. What do you see as an important non-reformist reform in our journey to the abolition of long-term care? Amit, I feel like you have done a lot of work in this regard, so I'm going to turn it over to you.
Yeah, sounds good. So once again, I'm just so grateful to learn from all of you. And I feel this is a learning experience for me to be a part of this panel. So thank you so much. So I think for me, step one would be removing the influence and the philosophy of private for-profit long-term care out of the system. Once again, it's just step one. We know that actually, and I will reiterate this point, is that you know, just doing that is not going to solve, you know, like all these problems here. But if we can remove the influence of these private operators and these large corporations, that means that we can divert that funding to actually providing care for people at home, for, you know, for where they want. We can actually, you know, possibly, and maybe this is speaking about the bigger picture here, we need a housing for all, you know, sort of policy as well, because we know that's better for the economy, it's better for people, and housing or homelessness is actually a condition which reduces life expectancy by 50%. We need to make sure that we provide people on ODSP, you know, money that is not well below the poverty line. People should not just even have the, you know, the money to, you know, for the bare necessities of life, but they should have the money to flourish, to actually live a life of dignity and prosperity. So I think that is kind of, you know, for me, some of the first steps. And I wanted to address this issue. I'm not sure if it's really what we're thinking about today, but I'll just share with you, it's on my mind in all humility. I hear a lot of conversations about how, you know, even this first step about eliminating for-profit long-term care is not possible. And a lot of people say, well, this is not going to happen and it's going to be too expensive and so on. And I wanted to sort of share that there are solutions to that. Number one of which is, of course, investing more money in home care so that you don't have to build expensive, capital-heavy sort of institutions and buildings. The second thing is that here in Ontario, at least, where it's perhaps more relevant, in 2025, basically licenses in 185 homes, which represents about 20,000 beds, are set to expire. So the government will have a choice and also has some time to plan for that, you know, for 2025, where they can make sure that those homes are transitioned to municipally funded nonprofit homes. The other thing is a lot of this I feel is related to financing, and the system is actually rigged so that private for-profit long-term care operators get access to capital very easily, which is subsidized actually through the taxpayer, right? So that they can build these new homes. And if we had a better system which would finance and provide more resources for home care, that obviously would be better. And that would mean that we sort of create networks as well to build legal and administrative capacity in nonprofit organizations which provide care in the community. And that sort of playing field simply does not exist at this time. So I think that there are solutions here. And I think that the number one solution in my mind is to start by removing this connection, you know, between private for-profit long-term care and our governments. I'll add one last point here, is that I think that actually these companies are fundamentally sociopathic, to be honest. They've generated sort of millions of dollars in profit, and many of them maintained or increased their shareholder dividend through the pandemic while receiving millions of dollars in a federal wage subsidy from the, you know, from the government. They then, you know, they could have in a way, you know, been the heroes in a way. They could have sort of hired more staff or at least done something to reduce their COVID-19 death rate. But instead, they abandoned people. They let people die in the most egregious of circumstances without care, without food and water, without sort of, you know, basic human touch or contact. And in those circumstances, like, I absolutely agree that this is not an industry which can be reformed or fixed, but it needs to be completely, you know, dismantled from the roots. And with that, I think this is the starting point once again.
Judith, do you want to jump
Yes.
in?
So it is gratifying to know that 185 licenses will end in 2025. I will make sure that we get some use that as ammunition. That's very good knowledge. Thank you very much. But there's the other truth is that Ford is signing. He's just announced. I can't even remember. Tens of thousands of new beds, and I can't even remember 20 or 30,000 new beds and 15 refurbished. And when he does that, they get 30-year contracts. So even at the same time as some are being closed, more others are being added. I also should tell you that I get really aggravated when we keep talking about developing beds as if it's some kind of bed factory. Okay. Okay. I did see one article that at least had the decency to talk about spaces, but now I see everybody talking about beds again, which makes me a little bit crazy. But so I agree. I mean, I agree with what you're saying. The other thing that it is about the for-profit, aside from the fact that it's corrupt and truly outrageous, is that turning old people into income units is so devastating to the way society sees them. That's their benefit, is to create profit for other people. And I think that relates to what Megan was saying, is that we, our society does develop systems that benefit those in power rather than those who are not in power. And so those are really critical issues. I think, I like to think that the fact that home care in most situations would be a much more economical approach, has some capacity, to emphasize that, although not to only emphasize that, because if you only emphasize that, then the government wants to pull back and say, well, it's okay for those people, but it's not okay for these people. These people need institutions. So I think we have to continue to say nobody needs an institution. People need various levels of support, but that kind of support can be provided in a variety of ways that are non-institutional. I sometimes don't remember all the things that I want to say until after I say I'm done. So I'm looking at my notes. I think that home care, home supports, but we really need a whole basket of approaches. Like, people talk about systems that have been developed often by parents, actually, where money follows the person. So a person who is part of a program, if they want to take that money and use it for something other than what they've been given in the context of a program, but they want something very individualized, they can use that. So things like money follows the person, direct funding, where people, I have a friend who is now in his 80s, and when he was 58, he had a major skiing accident, actually, and he is now quadriplegic. And that was just when the direct funding program in Ontario was getting started. And one of my great triumphs in life was I let him know. And for all these years, he's been getting direct funding. He's been getting somebody coming in the morning, somebody coming in the evening, every single day, for all these times. And otherwise, this is somebody who would have ended up in a long-term care facility and would have died long ago.
Judith, over to you, Nora.
Yeah, there's not much to add to Amit and Judith's comments. They were very wonderful. I'm not sure if people have been following the news of Jonathan Marchand, who's a Quebecer, lives in Beauport in a long-term care facility, and he's 45. And last August, he built a cage outside of the National Assembly and demanded that the government find a way to help him deinstitutionalize, so help him leave this long-term care facility. And very annoyingly and sadly, this past week, he was in the news again because the government's pilot project is being dropped. And so, it's like one step forward, two steps back. And unfortunately, they're going two steps back in in his advocacy, but that's, I mean, a lot of the demands of younger people living in long-term care and who are doing that activism. I think that we can learn a lot of ideas to answer this question from folks like Jonathan Marchand. And then the other thing that wasn't mentioned is I think that we need to also look at the workers and what they're paid, and making sure that they are able to make a living wage, more than a living wage, and full-time hours within these within these positions. That's really important, and that the education for all of the healthcare sector, all healthcare workers, is free. That college and university tuition fees are free, so that we don't also see that private logic driving the education of the people who are going to be providing the care. I think that's really, really important, and it's a little peripheral to the actual system itself, but not exactly, because of course long-term care relies on very low paid, mostly racialized, many immigrant, mostly women, doing really, really important work, but for less, like minimum wage. And so having to work in multiple facilities to be able to cobble together their livelihoods.
And they're often paid even more poorly if they're providing home care.
Yeah, right.
Yeah, absolutely. I mean, there's so many things to think about when we're talking about non-reformist reforms. One of the ones that I really like thinking about is the access to single bed units. So right now, you don't have access to single bed units when you are paying using ODSP or income support services. And so that means that we know that in 3-person rooms, COVID spread much quicker and there was much higher mortality rates. So that means, of course, that COVID was not only spread on an age basis, but also on a class basis, where those who are living in single rooms are only those who can afford to, and only those who then are afforded the privilege of continuing to live or living a bit longer. And I think that also when we're talking about switching to home care, we have to see it as an entire person and an entire basket of goods. Most recently, I have been on this rant against the city of Ottawa where I live, because they have changed all of their multi-unit dwellings so that a bunch of rental units that they're expanding. And all of them are 3.5 stories, which means that not a single unit in this entire expansion of the housing in urban Ottawa is accessible. Every single unit in these 7-unit buildings are made inaccessible. And so our access to rental housing and our access to bus services and all of those systems that are so important to being alive and being part of the community are supported. And then I think beyond that, when we talk about and when we look at the deinstitutionalization movement, I think there was some really big hiccups in making reforms. One of the really big ones was the expansion of institutions before they shut them down. And so this allowed for the systems to continue for much longer. This allowed for it to be a 40-year process because they built these new structures and said that they were better. And so we see this, for instance, with the Manitoba Development Center, where they said that the only services and the only way they could shut it down would be if they invested $40 million in it. And so when we talk about the expansion of beds and all of these things, I think it's really important that we look at the history of all of these things. And we know they also do this with prisons. Right now, we see the Kentville prison being proposed as a means to divert populations for better conditions for incarcerated people, but that is not true, because we don't need these conditions. We don't need these institutions. We have the access to services in our communities. And so talking about Jonathan Marchand's pilot project, that's a great way to bring in the story of Tyson Sylvester, who also locked himself in a cage. This one was in the Winnipeg Exchange District, and there he protested for multiple days and sought to bring awareness to the use of long-term care for young people. In doing so, he filed a human rights case, which the government heard, and they just settled. And this would provide supports for 30 people, 30 adults to transition out of long-term care. 30 people as a pilot project proposed by a PC government. Tyson doesn't even know if he'll be one of those 30 people. And so when we see these conditions and when we see these pilot projects proposed, it shows, first of all, that we can have these systems. We can have our community living amongst us. They know how to do it. They know how much it would cost, and they know what it will require, and they make the decision instead to not do that and to force people into long-term care. And they don't do that, and they force people into these smaller prisons that are better for them. And so I think that that is an exciting and important way to think about this, is that we can do it. We are doing it. It's happening. And we need to push harder for these projects, not just for young people, but for everyone who lives in long-term care. So for the past 70 years, we have continued to invest in, privatize, and normalize long-term care. This has been close to the only investment in the senior strategy for Canada. Provincially, we see that there are always more promises for more beds being built faster and stronger. But we know that these will not bring about freedom for disabled people or freedom for elders. Obviously, substantial investments and social changes will be necessary for abolition to be realized, and disabled people and elders to be cared for in a way that is dignified for both them and for the people doing the work. What do you see as necessary for the project of the abolition of long-term care? Amit, you're unmuted, so you can go first.
Okay, sorry, I feel like I have a bit of an unfair advantage. Nora and Judith, please feel free to step in at any time. I'm really happy once again to be a part of this panel, and I'm learning so much from you. So yeah, I mean, I thought about this question, and it's really definitely a very important question. I mentioned a couple of things, which I'll just mention again, which I think are important. So we need to stop legislating people into poverty and actually provide them, the resources and, the money and the equipment that they need to survive and live. And specifically, I mean, I mentioned ODSP. I talked about how everyone has a fundamental right to safe, affordable, high quality housing. I think those are important parts of how we're going to get there. The other thing I'll add is we often talk in Canada, at least, about our universal healthcare system, but we actually don't have a universal healthcare system. Our taxpayer dollars go toward hospitals and physician care only, and everything else is left out of the system. And through decades of neoliberal policies, our hospital system is grossly underfunded at this time compared to other OECD countries. So in terms of things that are left out, I mean, that includes things like pharmacare. It includes things like home care, as we've talked about. It takes out housing, as I mentioned, and it takes out equipment. So once again, all those things should be free and should be provided so that people can survive, live, and not just even survive. People can live fulfilling lives with dignity and prosperity and, reach their potential at home. But the other thing I'll speak about is specific to palliative care, which is my area of interest, of course, as a palliative care physician. So right now we have a system where palliative care, by and large, across our country is grossly underfunded. Only 1 in 6 Canadians, only about 15% of people receive home palliative care at the end of life. And that's when 100% of us will die one day. So we will all need some aspect of palliative care. And the other thing about this is that we are thinking about palliative care, not as it should be. Palliative care is actually an approach to care which is not just focused on end of life, but actually focused on improving quality of life and decreasing suffering, providing holistic support, which includes reducing physical symptoms like pain, psychological symptoms or emotional distress, spiritual support, and helping people sort of make decisions that, by understanding their illness and making the decisions best for them. So it's really not limited for people who are at the end of life. It can be provided for people who have chronic life-limiting illnesses, people who have many years of life left. And in fact, that's what the practice should be. But because resources are so limited, it's rationed to the point where people only get this approach to care, once again, often at the end of life, and usually, honestly, not at all. Right? When I'm mentioning 1 in 6 people getting home palliative care, that means 5 in 6 are not getting palliative care. Even in long-term care facilities where we've talked about, I mean, we want to deinstitutionalize them and so on. And many people are going into long-term care, sadly, with illnesses like dementia that are not curable, where we know they would need some basic level of care, which would include palliative care. Only 6% of people in Canada, as per the Canadian Institute of Health Information, received a palliative care approach during 2018. And I think that's part of the discourse that has been really neglected in the media, where we've talked about saving lives, and we should have, right? Of course, that's an important discourse when we talk about long-term care and COVID-19, but we haven't talked about the suffering that was going on in these long-term care homes. And that's something, unfortunately, I've seen with my own eyes that I'll never forget, but it really teaches me how we need, once again, universal access to palliative care. As a palliative care physician, I'll add that, I will fully acknowledge that palliative care, like any other area of medicine or healthcare, unfortunately, at this point in time, perpetuates, many of the systemic issues in our society, like ableism, like racism, and so on. And we do have some data that shows that, unfortunately, we don't collect race as a data point here in Canada, but we look at country of birth, and people who are, recent immigrants to Canada, people who are refugees, are much, much less likely to receive a palliative care approach in Canada. So this shows us, once again, we have a lot of work to do, and a reminder that we have a national framework for palliative care in Canada, which was developed by the Liberal government. I believe it was done in 2017. And like many other sort of important policy papers or sort of recommendations that have been put out by commissions and task force and so on, it's not funded, and therefore it's just sitting there. Right? Unless there's urgent funding, and unless there's, action that reflects, the real suffering and the material conditions of people who are living without palliative care and deserve, palliative care as a basic human right, that will not change. So I think that's also very important when we speak about this.
Yeah, I think it's so important to put that in context of our current system of medical assistance in dying.
Yeah, I was just going to mention that. Thank you so much. I think when I talk a little bit too much, I kind of just want to kind of not over talk. So thank you so much, Megan, for mentioning that. And Bill C7 is, I think, really important to bring up if you can, Megan. Thank you.
Yeah. So Bill C7, which was brought into law in 2021 during the COVID-19 pandemic, expands access to medical assistance in dying for anyone who is not close to end of life, but has a disabling condition or is disabled. Within context of long-term care, we know that so many people choose to access MAiD because of the conditions within long-term care. I'm thinking about Sean Taggart. I'm thinking about Chris Gladders. I think I'm getting Gladders, Taggart, and Rochambeau, and even looking at True Sean, who is one of the people who made the claim, who filed the lawsuit against the province for not being able to access MAiD. The primary reason that he was seeking and pursuing MAiD was not because of being disabled, but because of the conditions within long-term care that limited his freedoms such that he didn't have any. And so when we know that 6% of people have access to palliative care, that means so few people are getting access to that pain mediation, that treatment management, and instead are just pushed towards this system that the only option we have for the alleviation of suffering in many instances. So thanks so much for bringing that up, and I'm glad I could expand on it a bit. Judith or Nora, over to one of you.
Okay. First, I do want to say, because you said it, you mentioned before that you didn't have the statistics on young people in long-term care. We do have that data. We know in fact, we know exactly how many children, I mean, as of 2018, we don't have it for yesterday, but we have it recent. And I think it's on the SSAO website, but if it's not, I can certainly get it to you. But they divide it into people with who with disabling conditions and people without, which I haven't figured out why they're there, but they identify the age of children and the people under the age of 65. And so if you want that, I will certainly send it to you. One of the things, again, perhaps I'm taking a lesson from Amit, and I'm talking about what I want to talk about, even if it doesn't. But I think it certainly relates. You know, we talk about changing the system, and I for sure we have to do it. And people have said lots and lots of, in fact, there's been very little that people have said that I don't agree with 100%. But I am aware that, as I said before, you know, institutionalization, there's a certain mindset issue, and one of the things that happens is challenging or finding ways to change people's perceptions about certain populations. So the horrible assumptions about what people are like and about what they need, and seeing them just as a bundle of sickness and decay, and all they need is good health care and everything will be okay. Or for instance, that if somebody has some level of dementia, we have this horrible, horrible fear of dementia. And the assumption is that nothing can be done. The person can just be left sitting around doing nothing. The person is often considered like dead, okay, or non-human. So people say things like the person who used to be my father, okay, and all those kinds of things. The assumption that it doesn't matter what you do with a person with dementia because they don't know anyway, and all that creates an environment where people can do terrible things to other people. I read a book recently by a woman named Lynn Castell Harper called On Vanishing, okay, and there was some religiosity in it that I could have done without, but she made some very interesting observations about how people respond to people with dementia. And she said that, well, what happens is it's like a wall comes down and all of a sudden it's okay to do nothing at all. And she draws on other people's research who says that one of the things that happens is that the way that when people are diagnosed with dementia, the kind of treatment they get, the way they're treated, doesn't improve their dementia, it worsens it, okay? So you take people who are already having a little trouble coping with their environment and you put them into a new environment, you know, and then if they don't behave, you zap them with medication, you do all kinds of things that make them worse, okay? And she argues, she says, if you take the time to listen, to really get to know people, there's more there than we're giving people credit for, that most people are giving credit for. Another favorite comment I have is the book by Daniel Kahneman on thinking fast and slow. And he does this very nice bit explaining the difference between memory and experience. And he says, when people have no memory, people think that they don't experience anything. And he says there's a difference. And even people who don't have a memory can still, in the moment, they can take pleasure in things or they can suffer. But in people's mind, it seems, well, if they're not going to remember anyways, it doesn't matter what you do. And so all these things just feed the environment where it's seen as acceptable or even necessary to institutionalize people with dementia. And most of the people in long-term care facilities have some degree of dementia, or those are what the statistics have. And I wonder how many of them, I mean, I think many of them could still be supported, certainly not in institutions, because nobody needs to be with hundreds of other people, but I think many of them could be supported at home. And many people with that level of dementia are supported at home. Also in the, I had on my little notes to raise the issue of medical assistance in dying. And I should say that I make a point of always saying medical assistance in dying, not MAiD, because I think that we like to give pretty names to bad things. Okay, and so I also people use, well, I like the term death making to refer to all the practices that we impose upon people that bring about their death sooner than it otherwise would have been. And obviously medical assistance in dying is very direct death making, but institutions also are creating people's death. They're hastening it. Sure, everybody's going to die sooner or later, but for heaven's sakes, we don't have to help them die later. So I'm also concerned about elderly people's needs being being perceived as strictly healthcare needs. And I think that's a real problem. One, it leads to facilities that are incredibly medicalized and are modeled after hospitals and nurses and wards and all the paraphernalia that goes with that. But it also means that all the other needs that people have are just ignored. And I think that's something that we need to set. And I think that Amit I think people have sort of started saying this, but I sort of made my list. You know, one of the things that's helpful to think about are all the things that all of us consider as necessary for a good life. And then to say, how do we make that happen for everyone in society, including the groups that are currently devalued and treated poorly. And so I think we need to focus on care as a public good, and not, when I say care in its broadest sense, not just medical care and what we have to do. Again, and this of course brings us to medical assistance in dying, is we need to reaffirm the inherent value of all human life. I find the whole medical assistance in dying so dysfunctional for our society. Okay, that I can appreciate that people at a certain point it may be a rational choice to choose to shorten one's life right at the end, and I suspect that that's been happening for a long time. But when we legalize it and routinize it and normalize it, we encourage it. Okay, and the people who are the most at risk of being affected are the people who are the most devalued, and that's disabled people and elderly people. I obviously the home care, but I think it has to be constructed in such a way that people have control about how. I mean, I know I have a cousin who has serious issues and she has people popping into her house to provide some care, but she has no choice in that. No, they don't come when she wants. They don't do what she wants. They don't. I mean, it's very disheartening, you know. And I'm trying really hard to help her, but not doing really well. Again, the other thing, and these are, you know, we have a society that's very. People are very compartmentalized, and I am clearly one of those. I really didn't know that I was an old person until COVID arrived. Okay, then I found out that I was a really old person. But our society is very age structured, so old people associate with old people. Okay, and so if that's going to happen throughout their life, it's a little bit ingenuous to think that suddenly when they're old, we're suddenly going to find ways of having intergenerational environments for them. And so if we think that's a good thing, then we have to be building it in earlier than when people are old. Okay. So I don't know how to do it, but I think that we have to think about that. Finally, I think we should replace Ford in the next election. Okay. Okay. I'll stop there.
That's a great place to leave it. Nora, over to you.
Yeah, how do I follow up those two interventions? Basically, Amit and Judith, you've said it all. So I guess I'll step back maybe, and when we're talking about abolition and long-term care, I think we have to make the connections that have been made tonight, that abolition is not just something that we need to talk about in relationship to deinstitutionalization, but we need to look at abolition across many different structures of society. And so that means really like making a priority to talk about, what does prison abolition look like? What does our society look like if we deinstitutionalize prisons? And what are alternative forms of, like, how can we create justice systems that don't rely on incarceration, on throwing people away, and disposability? Because, as has been demonstrated, there's a direct line between these two things. And you know, like the point that I think Judith made of how, like, on one hand, it was easier to deinstitutionalize decades ago because they were all, like, facilities were all controlled by the provincial government, and now we have this like incredibly complex hodgepodge that just makes people go, oh my goodness, this is just too much. I just don't have any idea how we would do this. I think that you know, this is the result of neoliberalism, and when we're talking about understanding society, neoliberalism touches everything, touches every single aspect of the way that we interact with one another, and the way that we interact with the state, and the way the state interacts with us. And you know, this is where I think COVID is a very useful educator, right? That this pandemic has been a pandemic that has just like sought and destroyed every single aspect of society where neoliberalism has been the most ruthless and cruel. And it has torn open things for a lot of people that they didn't realize or didn't understand before. For many of us who've been talking about this stuff for years, it was like, oh my gosh, like you can see the freight train approaching, and you're like, it's still coming. We're not getting out of the way. And so when we're thinking about abolition, we have to be able to explain the role that the transformation of what was once a welfare state into the way that it works today at the service of profit above all else. It needs to be something that people understand, right? Like I think if you posed a question in March 2020 to the average person on the street, the government can choose to do this, and you know, 2,000 people will die, or they'll choose to do that and 17,000 people will die living in residential care. What do you think they'll choose? I think the average person wants to believe that the politicians are going to choose the thing that the fewer people are going to die, right? That the whole trolley kind of cartoon, if you're familiar with that. And if you're not familiar with that, it's not a big deal because it's not super illustrative to my point. But like, to see the fact that our politicians have chased profits, have done everything they can to secure, protect, and bolster the status quo, which is this neoliberalism, at the expense of 26,000 people dying total, and then, as I said, 17,900 dying in residential care. This is a wake-up call. And so when we're talking about deinstitutionalization and abolition, it's making sure that wake-up call is the word in French is vulgarized, is made to be understood by average people, right? De-jargonized, spread this popular knowledge around, so that we can actually have a very serious conversation about how, as has been said, like we're living in a society that worships death, that profits off death, that needs death. And I think that's one of the ways that we can approach this is through education and making sure that these kinds of radical thoughts start to permeate themselves within the mainstream.
Thanks so much. Yeah. Oh, sorry.
Can I respond? Okay.
Yeah, I would like to respond too, but go ahead, Judith.
Perfect.
You know, I sort of despair that we can talk people into it. Okay, I don't know. I like to think. I mean, certainly SSAO works really hard to get stories out and has managed to get some really good stories into the press. Okay, and has people are talking in a variety of places, and that's why I'm here today, because I think this is so important that it needs to be talked about. But I think that, you know, older people are seen as unable to contribute, as sick and dying, as a burden on society. If one more person talks about the silver tsunami, I'm going to scream. I mean, you know, it's just over and over and over again. It comes out, and I'm not sure how we begin to change that. And I would say, I think, as I said before, that as far as institutions for people with intellectual disabilities go, we did get rid of the large institutions, but many of them were replaced with smaller institutions, even very small institutions like 4 and 6 people institutions. And so it really requires a changing of people's mindset. And I do think that what we have found with people with intellectual disabilities, that the biggest thing that changes people's attitudes is getting to know somebody with an intellectual disability. Okay. And so I don't know. I mean, I'm not even, I'm not even suggesting something, but I think that it's a very long-term challenge. And I think that I agree, and I think we all agree that the people we need to convince maybe at the start is not the general public, but the people who make the decisions. And sometimes maybe that's not on the basis, it's on the basis of economics, for instance, or encouraging a pilot project. Okay, pilot projects can change a lot. The challenge with pilot projects is that they can be canceled. Like we had a pilot project on guaranteed minimum income, and then when Ford came along, he canceled it before it generated any data. Okay, and so I worry about pilot projects unless they're structured so that they have to complete to the point where we can get data on it. But I do think that there are ways we can do it, but I think that it's more a matter of developing some alternatives and expanded home care and showing people that it makes a difference. Telling them that it'll make a difference isn't enough. Showing them may have more impact or should have more impact.
Yeah, so I think, Nora, you've got us both thinking.
Yeah.
So thank you for that. I wanted to add that for me, it's even beyond politicians. Of course, we've got to hold the politicians accountable, but I feel that, these corporations and their lobbyists really view politicians as people that can sort of fall on the sword any day, and they'll sacrifice them. And whether it's a Ford or it's a McGuinty or a Trudeau, these are just sort of people who are cycling through power and really sort of symbols in on the front line and speaking to sort of what's going on in the bigger sort of picture behind the scenes. And that's really what worries me. And in this current climate, I'm worried that, although the public, I feel, has progressed on certain things through COVID-19, and I'll point that out. Even though we've talked about mainstream media, I think, maybe 2 years ago, I don't think people were talking about the working and living conditions of PSWs. I don't think people really cared, and people really recognized that that was an issue. People didn't talk about paid sick days. People didn't talk about for-profit long-term care. But as we've come to sort of discuss tonight, obviously we've got to go much deeper than just simply speaking about, let's give PSWs a $3, sort of wage increase and extend it, right? The problems go much beyond just sort of doing that. And that's not even going to help the working and living conditions completely for PSWs. I can talk about that and what I hear and what I see for a bit more, but I am worried that in this sort of time, people are very tired with the pandemic, and they are falling into a climate of cynicism or despair themselves around fundamental changes and overhaul of the system. I'll bring about to everyone's attention that recently, just 2 days ago, Angus Reid released a poll, and I'm sure maybe perhaps some of you may have seen it already, that showed that 75% of Canadians sort of want a drastic overhaul of the long-term care system. 75% of Canadians want to bring long-term care into the public system. And when they were asked, only 20% of people actually thought that politicians would make that happen. And that, to me, once again, points to the cynicism and despair that people are feeling. And somehow we have to realize, and we have to bring people together in almost a revolutionary sense, to really hold our politicians accountable and really realize that the politicians work for us. We do not work for them. They are working for us, and they are always accountable to us. And we have the power through collective social movements and uprisings to make this happen. And this is really what's troubling me at night, is that how do we get this collective social movement going? Because I think if we ask people, people are aware of a lot of what is happening, and they don't want to end up in those conditions. They don't. And it speaks to actually a lot of what we're speaking about in today's discussion, where, in that survey, they said 50% of people would do everything possible they could to avoid ending up in a long-term care home. I think it was just under 50%, and they would start saving up money. But do people actually realize how hard it is to remain at home? I mean, it can literally cost millions of dollars just for a few years of extra home care, you know, to be there. And if you have an illness which is longer than a few years, whatever, this is not possible. So all of us are actually, I mean, I actually tell my patients or other people that we're a serious illness or an accident away from ending up in one of these facilities where our bodies and our lives will be viewed as commodities and sort of a way to generate income for these companies rather than, you know, someone who can still have a fulfilling life and deserves, you know, respect, dignity, and care. And as Judith very importantly outlined, doesn't just deserve medical care, but deserves, you know, all aspects of care and integration into society rather than separation from society. But anyways, getting back to my main point, this is actually what troubles me, is that people will just sort of fall into this cynicism. And as Nora has outlined, I think this is something which is not unique to sort of many social, you know, or it's not unique to this conversation about deinstitutionalization, but it's also something which pervades, you know, discussions around climate justice and, you know, issues, you know, that are, you know, also being discussed that are very important for actually our survival.
Yeah, I think one of the feelings that sticks with me as we like are in maybe this the dip in a large ongoing set of waves is that I think lots of these conditions and lots of these settings were not even brought to public attention. And this was my frustration this entire pandemic. And this really made me and continues to make me panic because the conditions are so urgent. Like there is such an urgency to what people are experiencing and what people are forced to endure every day. And it's difficult to both explain to people how urgent this all is and what the conditions are and how dangerous everyday life is in these settings, and for them to understand what is required and what is happening. I think especially for people labeled with intellectual disabilities and for people who are leaving the carceral system and who are older, they're reinstitutionalized into settings that never make mainstream media, or if they're named in, or if they make mainstream media, they have the wrong name. And with so much of the COVID data that I have been struggling to gather, it's because it puts people's privacies at risk, or it that's what they say, even though these institutions are often the same size as long-term care, are often operated by the same actors as those in long-term care. And so I think I feel this and like am constantly aware of this panic and urgency that is required. And it feels like a very long road, but one that I hope that we can continue going down. But it does feel like many days. It's like, how much louder do we have to scream, or like how many more people have to die? Yeah, Nora.
Yeah, so this starts to get into like the world where I'm much more I wouldn't say an expert, but certainly I have a lot like more concrete kind of ideas about what it takes to actually force political change, right? Because it, as Amit says, like it isn't about the politicians, and I totally agree. We have to do the political thing. You know, you have to put on a suit and lobby if you have to lobby. That can be part of what left-wing activism looks like. But the problem is it goes back to neoliberalism, right? So neoliberalism destroyed, it was intended to and succeeded at destroying our senses of community. And there are, of course, communities of people that maintain that sense of community, and then they often become criminalized by the state because that community becomes a threat. But for the vast majority of people, they no longer have that community. And so we sit around and we're like, we have no way of changing political positions because we fight and we're in the streets and we lobby and we do what we can and we have the facts and we have the arguments and nothing changes. But nothing changes because we're in a moment where our social movements have not caught up to the fact that they were just destroyed by neoliberalism, right? It took like 20 years for a lot of them to kind of hobble along and go, oh my gosh, collapse. And so in the 2020s, we've just finished a decade with very interesting social movement groupments, right? Like the rise of Black Lives Matter, the rise of Idle No More and Indigenous activism, the rise of climate justice that's been remixed out of like centrist, close the lights or recycle kind of thing, into an actual radical climate movement. But 15 years before these things appeared in the mid 2010s, was a real dead zone of social movement organizing, which isn't to say there was no activism. Of course, like I was involved, like lots of other folks, I'm sure on the call have been involved with this stuff. What we need to do is we need to reconceptualize our social movements in this neoliberal age. And what that looks like can only happen when you bring people together in a room where they can hash it out and it's not being mediated by social media, and we're able to speak directly to one another, to be creative and say, okay, where are the pressure points within government and how can we bring a government to its needs? And that is not the kind of conversation that we've had yet. I think organizations like the Disability Justice Network of Ontario are exactly the kinds of things that need to build out and figure out, okay, how are we going to put that kind of pressure on our governments to force them into to actually take action? And it's just that we're just not there yet. Like we just actually have to have these discussions, and we were just about to get there, and then the pandemic made it impossible for us to even be together in any like realistic way. And so I think that people need to think about that the social movement organizing side of all of this is really, really, really critical. It is the way, it is the answer. It passes through education, it passes through mobilization, it passes through radical action, it passes through intergenerational solidarity and learning from one another. But that is the piece that we have to really build, because that's the only way that we're going to make the kind of changes that we're talking about tonight.
Yeah, also just building off of that, I think we often say that these things can't happen through mediation of social media, but for so many people, especially within the disabled community, that's such an important and often necessary mediator because of these systems that we create. So I think, for instance, about AAC and various other services that are only available online. But I think further to what you're saying is that we have now a generation, Gen X, who were completely brought up through and baby boomers through the neoliberal era and are really not part of this and part of many of these conversations, but are not yet elders or requiring mediatory services. And so many of them are completely antagonistic to the idea of community care. And so I think that is one of the things that we both have to learn how to do is participate in community networks of care, because it's been brought up so many times tonight that, we think of family care as the only other option to living at home and how that will deplete resources. But actually, we require so many more people than just our family. And that's why we need to, include more people and include the entire community. But we also will have to teach a lot of people how to be cared for and how to be part of those communities, because they've been so not excluded from them and told that they're bad and told that they are not part of this system. And so I think it's also a really important time to begin and continue engaging in mutual aid practices and being comfortable with both giving and receiving care, and not necessarily always commodifying those interactions, but simply providing them. I think like cooking for our neighbors and offering rides to doctor's appointments and all of those things that we have that keep each other alive, but that we don't necessarily offer to people, especially to our disabled community. And so I think we're getting there, but I think a really important part of that process will be developing those community care systems, which Disability Justice Network of Ontario does such a good job of through things like the grocery services through the pandemic, and just so many various services, the vaccine clinic, and all of these amazing pieces that help keep each other alive and keep each other safe. And with that, I think we'll wrap up. Wondering if people have a resource they would like to share or where they can follow you and your work. Whoever wants to go first.
Well, I would certainly recommend that people check out SSAO's website. There's some very good research reports on it, editorials, but a lot of information that that has been compiled there. So I would certainly recommend, and it's Seniors for Social Action is what you have to Google to get to it.
Also, I would say some of the best posters out there. Amazing.
Yeah.
It.
Yeah, sorry, go ahead.
No, you go ahead.
Yeah, so I was just going to say that once again, I'm part of this coalition, Doctors for Justice in Long-Term Care, and I will share that some of the learning that I've, been privileged to take part in this evening, I'll be taking back to our core committee, and we'll definitely be having some further discussions about this. But our website is available if we just look it up, Doctors for Justice in Long-Term Care, and we're also active on Twitter.
Cool. Folks can find the spreadsheet of deaths in residential care in Canada if you're interested in that. I post it every night that there is a death, which means actually in the last 2 weeks it's been really slowing down. So that's, I mean, a small bit of good news. And you can find that on Twitter. It's a Google document, so you can Google deaths in long-term or deaths in residential care Canada COVID, or you can find me on Twitter, which is at NoLore, NOLORE, and it's my pinned tweet. You can see the spreadsheet from there.
The spreadsheet is truly amazing, and I look at it every day. So thank you, Nora. And you can follow, of course, the Disability Justice Network of Ontario at DJN Ontario. And you can follow also Invisible Institutions, where we talk about institutionalization across Canada. We're on Twitter. Oh no, we're on Instagram and have a website, invisibleinstitutions.com. And you can follow me on Twitter at Pink Cane Red Lip. I have pink lip today though. I was using my red cane. It was so good to have you all, and there will be a recording of this on our website and our YouTube page.
Good. Thank you.
Thank you.
Thanks, everybody.
Nora, I'm so amazed at your ability to multitask.
It's amazing what's going on around me too, because there's a party just started behind me.
What's that in front of you? What's that black thing in front of you?
This is gonna blow your mind.
Sorry, I just asked.
Are we done? Are we
Oh,
done?
that's what that is. Yeah, my mind is blown.
See these there's two little pegs here, and it is perfect. It is perfect. Yeah, and so everyone who's still watching, you can see how the magic of, it's Hollywood magic in at this motel.
The innovation.
Yes.
See, I feel like we reached the perfect time. 7:47, everyone. That was
Yeah. No, it was wonderful. I mean, that was really wonderful. And Judith, if you're still on the call too, thank you so much.
Yes.